She obtained her medical degree from the Lake Erie College of Osteopathic Medicine and then obtained her MPH from the School of Public Health at the University of Albany. She then went to Dartmouth for her internal medicine training and then continued there through cardiology as well as interventional cardiology fellowship. We were lucky then to have her join us about 3.5 years ago, and she's now an assistant professor of medicine here in our very own cardiovascular medicine department. She's also the associate program director of the Interventional Cardiology Fellowship Program. She's interested in coronary disease and is our CTO operator here at Yale. And personally, she's always been an absolute pleasure to work with. Today, she's going to discuss CTOs and how the practice have evolved over time. So now I'll turn it over to Dr. Frampton.
Thank you. So yes, we're going to get started. We're going to talk about CTOs and where we have been and where we're headed. So these are disclosures. I wanted to start off by thinking about joining interventional cardiology. It's always very important to have a really supportive group of friends and family. And so one group that has been a big support for me has been a group of guys that I trained with. And so along my CTO journey, they are incredibly supportive with several comments. Even if the patient doesn't feel any different, the operator always feels great after a successful CTO PCI. When I told them that I was preparing grand round slides, oh, it's for Yale, so make sure you bring all the randomized controlled data on improved mortality with a wink and a laugh, prompting the EP friend to say, LOL, here's my slide showing the improved mortality data, followed by a blank slide. So with that, we're going to dive into some of the data that does exist and where things have gone over the last several decades. So the first successful CTO was performed in 1984. This was with antegrade wiring. Retrograde CTO PCI came several years later, initially through a saphenous vein graft. And then even more years later, it was going retrograde through a native artery through a septal collateral. Until 2010, most of the CTO PCI was done through antegrade wire escalation. However, there has been somewhat of a shift in that since then. And then during that timeline, there was also the adoption of dissection reentry techniques that were really taken from the peripheral space. So here is a timeline of some of these milestones within CTO PCI. So development of stents, of course, and then actually having equipment that was made for CTO PCI, introducing the retrograde approach, having equipment that was made for dissection and reentry. And those all kind of happened in that early 2000s to 2020 range. So what do we know about CTOs? Of course, 100% occlusion with TIMI zero flow that's been there for a duration of at least 3 months. It's common. It's seen in up to 20% of patients that are sent for diagnostic angiograms. The most common reason for pursuing CTO PCI is, of course, for symptoms, and we'll talk about that in a bit. Certainly, angina can be a symptom, but probably more commonly is dyspnea on exertion when it comes to CTOs. Overall referrals for CTO PCI, despite it being 20% of patients that have diagnostic angiography, is still low in about 10 to 15%. However, referrals for bypasses of CTOs is certainly much higher. We also know that CTOs in the post-bypass population is a huge problem. We'll talk about that as time goes on with this talk. So for patients that have a bypass surgery with a vein graft particularly is really where the problem lies. We know that they may not have had a CTO to start, but they will eventually have one, according to the statistics. About 54 to 89% will end up with a CTO in their native vessel due to the aggressive nature of the native coronary disease and the progression of atherosclerosis. So we'll talk about that a little bit more, but first we're going to talk about the trials that do exist that have looked at CTO PCI. So there have been 5 randomized control trials, and we'll look at each of them individually. And then there has been lots of observational data that has had mixed results. So the first trial, this was the Explore trial. It was published in 2016. And this was developed on the idea, or I should say the data, that told us that patients that have a concurrent CTO and present with a STEMI don't do very well. So they have increased mortality and morbidity. And so what they did with this trial was they took 304 patients who underwent primary PCI for their STEMI and also had their non-infarct artery with a CTO, and they randomized them to either receive CTO PCI pretty quickly within a week of their initial procedure versus medical therapy. And what they looked at were the outcomes of the LVEF and the left ventricular end diastolic volume on cardiac MRI initially and then 4 months later. And what they saw was that at the 4-month mark, there was not a difference in the mean LVEF or the mean left ventricular end diastolic volume. Although not powered to look at the major adverse coronary events, there was no difference between the two as one of their secondary outcomes. But interestingly, when they did a subgroup analysis, they saw that patients that had a CTO that was located in the LAD who had received CTO PCI did have a significantly higher EF compared with the OMT patients. So overall, drawing the conclusions from this, they did not see a benefit in terms of the EF or the end diastolic volume, but there may be potentially this group that have a CTO of their LAD that may benefit from revascularization. This was followed by the REVASC trial, which was published in 2018. And this was to look at whether or not PCI of a CTO will improve LV function. This similarly used cardiac MRI to look at segmental wall thickening. And what they saw was that at 6 months, among the patients who were randomized to CTO PCI, that there was not a difference in segmental wall thickening, and there was not a difference in LVEF as well. Similarly, there was an interesting finding with this subgroup analysis. Essentially, what they saw was that in patients that only had a CTO, so really didn't have other cardiac lesions, those patients seemed to benefit more from having CTO PCI with a larger improvement in their segmental wall thickening. When they looked at MACE, there was a difference that was statistically significant, driven by repeat intervention. I'll just mention this briefly, but the Impactor CTO trial was a relatively small trial at just a single center, 94 patients that were randomized to have CTO PCI of their RCA, and the outcome was looking at reduction in ischemia and improvement in their quality of life, and they found that there was not a difference between the two groups. The EuroCTO trial, which was published in 2018, this one I think is probably the most important one, or at least the most commonly talked about trial that we'll discuss. And so this was a trial that was made with the goal to evaluate how patients do as far as their angina goes with receiving PCI plus medical therapy versus medical therapy alone. And so they studied 396 patients, and their primary outcome was based on the Seattle Angina Questionnaire. Importantly, they took patients that had an obstructive lesion and revascularized them at least 4 weeks prior to randomization. So there was no kind of confusion about what they could be experiencing their angina from. So all patients with obstructive lesions were treated for their obstructive lesions and then randomized afterwards to either PCI of their CTO or optimal medical therapy alone. At 12 months, they saw that CTO PCI showed a greater improvement in angina frequency and quality of life, and that those patients who did have CTO PCI had significant improvement in their physical limitation. They saw that the major adverse cardiac and cerebrovascular events were low and similar between the two groups. Following up on this trial, they looked at the 3-year outcomes, and at 3 years, similarly to what we saw with the initial 1 year, there was no difference in the incidence of death or non-fatal myocardial infarction. MACE was not different between the two groups. And so this is illustrated here, again, no difference between the two groups as far as that endpoint goes, but there was the difference in the treatment of angina, or how patients describe their angina afterwards. So this was followed by the Decision CTO trial, which is also a very important trial. It's talked about quite often. And here, patients were again randomized to receive either PCI for their CTO or optimal medical therapy. Different from the Euro CTO trial that we just talked about, their other obstructive lesions didn't necessarily have to be intervened upon, so not necessarily comparing apples to apples, so to speak. They may have had other obstructive lesions that could be playing a role in some of their symptoms. They did study a primary endpoint of a composite of death, MI, stroke, or revascularization, and they also looked at their symptoms of angina as well. Also important to note, the trial was stopped before they were able to enroll their goal of 1,284 patients, and this was stopped due to slow recruitment and enrollment. So what they were able to enroll was 834 patients who were randomly assigned to CTO PCI or no CTO PCI or optimal medical therapy. And then also importantly, almost 20% of those who were randomized to the OMT group ended up crossing over to receive their PCI, and that was within 3 days of randomization. So certainly some faults within the study design overall, but with that said, there was no difference in the primary endpoint, as you can see there. And both of the study groups had a substantial increase in their quality of life that was not statistically different. So pulling all of that together, what can we say about the randomized trials that exist? Well, no randomized trial has shown that there is any improvement in mortality associated with CTO-PCI. Among the few trials that do exist, there's of course limitations as there are with many studies, but particularly with Decision being the larger of the trials and having quite a bit in the way of limitations there. The Euro CTO trial did show that there was an improvement in symptoms who underwent CTO PCI versus those with medical therapy. And then there is this suggestion that perhaps there are some subgroups that might benefit from CTO PCI. So perhaps those with a LAD CTO, or perhaps those that only have a CTO and no other significant coronary disease. And then on top of that data, we have several observational studies that have looked at different things within CTO-PCI, and some of them have suggested that there is an improvement in myocardial function, potentially in survival, and potentially in the reduction of arrhythmias. And we'll talk about some of those studies here. So ventricular arrhythmias, of course, we all know, huge problem when it comes to patients that have CTOs. And so this VATCO trial, with their 162 patients with an ischemic cardiomyopathy, they took a look at who was receiving or who was having arrhythmic events after they had their ICD placed for primary prevention. And what they saw was that over 30% of the patients that had a CTO were having these arrhythmic events over the 3 years of follow-up, whereas 90% of the patients that didn't have a CTO were not having any ventricular arrhythmia events. This prompted the VATCO PCI trial, and this was the VATCO 1 and 2 group that were looked at, so a total of 622 patients. And what they looked at were those that had received PCI versus optimal medical therapy. And at the 5-year mark, they noted a pretty big difference between the two groups. So those who had CTO PCI had appropriate ICD therapy 20% of the time versus 56% in the patients that did not have CTO PCI. And then at 5 years, the PCI group had a mortality of 8.8% compared with 23%. So these are the curves that are here. And as you can see, they separate and show the difference between the two groups that have received CTO PCI versus optimal medical therapy. And then down here, you can see the number of appropriate ICD therapies. The medical therapy group certainly had much more in the way of ICD therapies versus the PCI group. So there have been some studies that have been published looking or attempting to look at long-term survival. And they are somewhat limited. These are all observational trials like we talked about, but we'll take a look at some of them here. So this was an observational study that was published in 2014, and it was looking at the longer-term outcomes for these patients. As we talked about earlier, when we looked at the outcomes for our randomized control trials, really just the 3-year mark was the longest that we had seen. And so here they were taking patient PCI CTOs between 2005 and 2009 and looking to see how they did as time went on. CTO success rate was around 70%, which is pretty standard for these trials and really all of the trials that we've talked about so far. And so truly not comparing, PCI versus optimal medical therapy, but really looking at revascularization of a CTO and complete revascularization versus partial revascularization. And so what they saw here was that the patients that had more revascularization tended to do better as time went on. There was an improved long-term survival among the patients that had had successful CTO. And the improvement was the greatest when patients had had this complete revascularization. So limited, like I said, certainly not comparing medical therapy to PCI, but either way, showing that perhaps there is a benefit in the long term among these patients that have PCI. Similarly, this was a meta-analysis that looked at a total of 25 studies and was able to combine over 28,000 patients with that similar procedural success of 71%. And here they compared successful CTO PCI versus unsuccessful. So again, a pretty similar comparison there. The patients who did have successful CTO PCI had lower mortality, less angina, lower risk for stroke, less need for CABG, and lower risk of MACE overall. So compared with failed procedures, they were able to say here that successful CTO PCI was associated with better outcomes. Other things that I just want to mention that are important and come up very often with regards to data. Patients presenting with a STEMI who have CTOs of their non-infarct artery, we know that they do worse, right? And there's been data that has shown that in both the early and the long term that they don't do as well. And so that's always a consideration that's discussed as well. There is some data to support that when there is a very large amount of ischemic myocardium of greater than 5%, some other studies saying 10%, that perhaps the survival would be better if they did have CTO PCI. And this subgroup seems to importantly be that LAD subgroup. And then with regards to complete revascularization, I think that's something that we, of course, talk about all the time. And we know that in the STEMI population that patients definitely do better when they have complete revascularization. When you look at those trials, there was a subgroup of, or not a subgroup, but there were patients that had CTOs, and it was really at the discretion of the operator. So as far as how to include that, it's not really clear. But seems overall that complete revascularization may be in favor for patients after they've had an event like a STEMI. So where does this leave us at this point in time? So these are from the 2021 guidelines, and it continues to be a 2B recommendation to go forward with CTO PCI, and the indication being for patients that have stable angina. So that's really kind of the history in the past of where we have been with CTO PCI, but now I'm going to shift a little bit to talk about the present and the future and where things are going. So there has been a lot of enthusiasm within the CTO community to improve success rates and also to improve safety when moving forward with these CTO PCI procedures. Of course, as we all know, there's a higher complication rate among CTO PCI compared with regular PCI. And because of this, there's been a focus on developing investment procedures and having that be the expectation of the patient, and particularly with working through subintimal tracking and reentry and subintimal plaque modification. So we're going to talk a little bit more about that. So of course, as we all know, 3 layers of our coronary artery, the intima being the innermost, the media, and then that nice strong adventitia around the artery. And so what are we talking about when we say subintimal tracking and reentry? So this is an intentional dissection into the subintimal space and pushing a jade polymer jacketed wire through the outside of the occlusion and then spontaneously re-entering the distal vessel. And so this is not a new technique. This has been done for many, many years, but it was previously seen as more of a bailout technique. So if you were not able to cross with antegrade wiring, or if there were not retrograde approaches, then there was this shift towards doing STAR and then trying to finish the procedure then. And so as you can imagine, a lot of dissection, you're losing side branches, and a lot of stent that had to be done at that time. And so as opposed to it being thought of as a bailout technique, it's now kind of thought of as, in many centers, like the first line of what you should do is to intentionally dissect and then spontaneously re-enter. And this is in the thought process that it would be an investment procedure, that you bring them back 8 to 12 weeks afterwards and let the dissections heal and adjust the cap, most likely, or the hope is that you have adjusted the cap. And then when they come back, they end up with shorter stents, a lot more vascular healing, and they do better overall. And so how do we do this? And why is this different now than it was 20 years ago? Well, of course, there's been a lot of technology advances during that timeline. So there are dedicated coronary wires that have been made really to do this J or this knuckle. And so the Gladius Mongo is a polymer jacketed wire that will form a really tight knuckle, so it minimizes hematoma formation. The Pilot 200 is also a polymer jacketed wire that likes to knuckle as well, and that will form a bigger knuckle so that it avoids side branches. So the thought is that you would initially start with the Pilot 200, traverse that along the side of the occlusion, avoiding side branches during that time. And then once you get to the distal cap of the occlusion, bring your microcatheter down in exchange for a Gladius Mongo, which has the ability to spontaneously re-enter into the distal vessel. So the development of technologies has played a role in this. Also, the use of IVUS just helps us to understand when we're subintimal and when we're not, and also tells us a lot about the vessel too, with regards to calcification and that sort of thing. So this idea of STAR, or this procedure, has been really adopted in most very busy CTO centers as, like I said, often the first line of therapy, and then bringing them back for deferred stenting 8 to 12 weeks afterwards. With looking at the literature that exists on people who are doing the STAR procedure and then going with delayed stenting, they have had high rates of technical success, almost 90% on their repeat attempt after 2 months. There was the STAR trial that just finished enrolling their 150 patients, and they essentially were looking at what's the best timeline to bring them back for their second procedure, either 5 to 7 weeks or 12 to 14 weeks. CTO Plus is later this week, and they plan to present the results there. So we'll see as far as what the recommendation will be for optimal timing. Subintimal plaque modification is certainly not as well studied as STAR and still considered a bailout strategy, whereas, like I said, STAR has really shifted away from that. So subintimal plaque modification, same initial steps as what you're dealing with STAR with the polymer jacketed wire, but then there's no goal, or you're unable to get back into the true lumen of the vessel. And so if you stay within the subintimal space, you can still balloon, and that's the recommendation. You do 1-to-1 with the distal vessel size. And the idea would be that you're adjusting that cap, right? And so you may make an ambiguous cap unambiguous. You may end up with a shorter occlusion. There'll be less resistance when you bring them back after they've healed for their return procedure, also in 8 to 12 weeks. This is also being looked at really for patients that have very high JCTO scores, so patients that have incredibly challenging CTOs. There is the thought that perhaps this would be a really good initial first strategy for them to use. So that's ongoing. But overall, I think STAR and SPAM have certainly changed a little bit in the way of CTO PCI and have made it safer. It just is up to us within interventional cardiology and cardiology in general to set that expectation for the patients. And so whenever I consent a patient for a CTO, I always tell them that there is a very high likelihood of needing more than one procedure for this. I think as long as you have that expectation and they understand that it's for their safety, that that has been working for many centers. So where have we come as far as success rate goes and what we're doing in the cath lab now? So the CTO PCI success rates previously were around 60, really 70%, and now they've improved when you look at dedicated CTO PCI registries to that 80 to 90%. And what does this do to? Well, I mean, certainly there has been growth within the CTO community. There's a lot of focus on teaching CTOs and even doing fellowships for them. There's been advances in equipment, of course. There's specific wires for CTOs. There's specific microcatheters. There's been the adoption of investment procedures, and that has played a role as well. And then, like we talked about, intravascular imaging is very helpful in letting us know what space you're in, if you're in the subintimal space, and understanding the vessel anatomy. So with all of that combined, there has been overall some progress, certainly. So what about the future? So certainly SPAM and STAR are still being studied. So I think that's exciting and will better understand the place and the role that they have. Noble CTO is a trial that has been enrolling for several years. Seems a bit slow, but their plan is to look at the difference in patients who receive PCI versus medical therapy, with their primary outcome to be mortality as well as quality of life. Goal is to enroll 2,000 patients. I'm not sure where it stands, but I know enrollment has been slow, and that has been some of the difficulty with studying and understanding CTOs. Similarly, ischemia CTO, this is a bit of a different thought process here. So the authors are here thinking that asymptomatic patients that have this greater than 10% burden of myocardial ischemia, that for those patients, PCI may be superior to optimal medical therapy. Those are in asymptomatic patients, and that symptomatic patients that have greater than a 5% burden of myocardial ischemia, that they also will do better than patients on medical therapy. So also has been going on for several years, also has an issue with slow enrollment and with a goal to enroll 1,560 patients. So we will see where that all comes out. So I wanted to shift now to talk about some common clinical problems that we run into when we're all trying together to better understand how we can treat our CTO patients and what is really best for them. So first, we're going to talk about imaging studies and how that can be helpful or not helpful in understanding who should get CTO PCI. So imaging studies are super important. That's often the first step, and that's how patients get to us, is that they had complained of some symptom, they underwent a stress test, and that showed ischemia, and they end up in the cath lab as a result. So it's important so that you can correlate with the patient and so that you can understand how much ischemia you're really looking at. From there, if it's a CTO, then often comes the further discussion about viability. And it's very controversial. So there's studies both in favor and against looking at viability for CTO PCI and how it should be used in guiding revascularization. And I should say, not even just in the CTO realm, but it's just in coronary disease in general. And so then there's the question of what imaging study is best for looking at viability. And we'll get into a little bit more of that, but these questions don't have clear answers, and it makes it even harder to understand what type of testing would be potentially helpful for these patients. I wanted to mention this trial because it is very frequently talked about within the CTO community, although it is a very small trial. So here, this was 27 patients, an observational trial where they evaluated cardiac MRI to look at LV dysfunction and a viable territory. And so the patients that had received CTO PCI that had a viable territory did, on their cardiac MRI, did have a decrease in the mean end systolic volume and their end diastolic volume as well. Their ejection fraction did not change significantly, which is certainly notable, but they also saw that the cardiac MRI had quantified how much transmural extent of infarct that they had had. And those that had the lower amount, so less than 25%, seemed to benefit more and had greater improvement in their segmental wall thickening after CTO PCI versus those that had had greater than 75% of their transmural extent of infarct. And so the authors here have concluded that in patients with LV dysfunction and a CTO in a viable territory, that revascularization with PCI had an improvement in the short term from this initial study, and then they did follow up in the long term 3 years later with similar results. So what do we do about identifying who will benefit? I think that answer is really unclear, and I certainly don't have a great answer for that. So there are tons of imaging modalities, and I think it's somewhat patient specific to try to better understand what is going on with that patient. It's important, if you can, distinguish hibernating myocardium from non-viable myocardium, and that's a limitation within cardiac MRI. The optimal choice should really be based on each patient and with the understanding that no modality has been proven to be predictive in understanding which patient is going to benefit from CTO revascularization. So here are some of the frequent imaging studies that we obtain. Generally, everybody ends up with a transthoracic echocardiogram. That tells us, of course, about overall LV function, can let us know about akinesis versus hypokinesis versus normal segmental thickening. Here with the myocardial perfusion imaging, they highlight the biggest benefit being the ability to identify that hibernating myocardium, and with cardiac MRI being the other option as far as looking at viability. The next thing that we're going to talk about is the impact of collaterals. So collaterals are super interesting. They develop during prenatal cardiac development and many regress, but some are retained. And then they develop when an area of the heart is without good blood flow in order to prevent myocardial necrosis. The presence of robust or well-developed collaterals is something that is talked about all the time within the CTO community and just within interventional cardiology in general, where there had been this thought process that that mattered as far as, you know, burden of ischemia, viability of that area of myocardium. But truly, that's actually not the case. And although we have a question mark on many things within CTO-PCI, this actually has really good evidence that collaterals and robust collateralization or well collateralized vessels are not really predictive of who is going to benefit from CTO-PCI versus not. And so what we have seen is that both non-invasive and invasive studies have shown that even in these patients with these robust or well-developed collaterals, that there's significant ischemia at rest. And then of course it worsens when they exert themselves or have any exercise. They say they have also seen that despite the development of collateral circulation, normal coronary blood flow is found in less than 10% of these patients. So they also have looked at whether or not this has any impact on the viability of the myocardium, and it does not. So it does not mean that that area is more likely to recover if you do CTO-PCI. And then what we also know is that the collateral is stealing from the donor vessel, right? And so this often comes into play when, say, you have a right coronary artery CTO and you have an LAD that's giving septal collaterals to it, and you have, you know, what might normally be a moderate grade lesion, but because that collateralization is stealing from the LAD, it plays a pretty significant role in ischemia of that territory as well. And so this has been pretty well studied. And it also is a reason that generally we don't IFR or FFR a lesion like that, because we know that there is an impact from the collateral flow. So I think here there is enough data to kind of make some conclusions that it is a misconception that well-developed collaterals are supplying adequate blood flow to a CTO territory to avoid ischemia. We know that it doesn't really mean much of anything and that it's not a marker of viability. We know that collateral flow can have a negative effect, particularly on the donor vessel, and lead to coronary steal. And so truly it should not influence decision-making when you're thinking about CTO-PCI. The presence of robust or well-developed collaterals should not be part of that decision-making. So what about post-CABG CTOs? So these are a huge problem within the CTO community. And it is going to be more of a problem as time goes on because people are living longer after their CABGs. And we know that patients that have had a CABG have accelerated atherosclerosis of their native vessels. Generally, what we're talking about is patients and their vein grafts, right? So 20% of vein grafts fail within 1 year post-CABG, and an additional 20 to 25% will fail 10 years post-CABG, which is really quite a large number. In the meantime, before their vein graft may fail, they are getting terrible atherosclerosis within their native vessel, and oftentimes a vessel that did not have a CTO to begin with will become a CTO during that timeline. And what does this lead to? Really challenging cases as far as trying to open up their native vessels after their vein graft has become occluded. There's a much lower success rate in CTO-PCI of post-CABG patients. And again, this is because of that really aggressive disease that they get in their native coronary arteries, where they have seen more inflammation, fibrosis, calcification, negative remodeling. So in reading about this, you know, histologically, this shows what a native vessel looks like after a CTO occlusion post-CABG. But I think that the CT image really kind of tells it all here, where you see the right coronary is just completely filled with calcium and really aggressive coronary disease after it has had that bypass from before. So I think that this brings me to talk about hybrid coronary revascularization approach, which is still, not well studied. There's not been good randomized controlled data to really understand what patients will benefit from this. But this is the idea that you are taking the long-term benefit of a Lima graft and doing that for a patient with a sternal sparing, ideally with a sternal sparing approach or robotic assisted endoscopic surgery. And then you're taking the arteries that you would have put vein grafts on and doing PCI for them. And so the whole idea here is that you are not having to deal with the vein graft problems that we see every single day within the cath lab. This idea is also that there is reduced bleeding, ventilator time, a decreased length of stay when compared with traditional CABG. And so there have been kind of smaller studies that have looked at it, looking at this approach versus PCI, looking at this approach versus CABG. I don't think that there's anything that is like really one way or the other as far as good randomized data goes. But I think that this, intuitively makes sense, right? So if you are going to give the patient a Lima graft, then they will get that long-term benefit. But if you're also preventing them from having the saphenous vein grafts and you're doing a more minimally invasive surgery, then you're also giving them that benefit as well. And so there are certainly centers that have shifted more towards this. I don't know that we have really done as many procedures like this, but I think it's worth considering when we're thinking about all of the problems that come with vein grafts and how much longer people are living now, and how, coronary ischemia really plays a big role a lot of times in their life and how they're feeling on a day-to-day basis. So where does this leave us as far as the indications for CTO PCI? So just as an FYI, this is written by a CTO operator, but the indication obviously that we all, I think, can agree upon is for persistent symptoms, right? So for patients that have anginal symptoms that are refractory to maximally tolerated therapy, that is an indication for CTO PCI. Then it gets a little bit more cloudy from there, right? So the left ventricular dysfunction with evidence of a large area of myocardial ischemia or with evidence of viability, potentially they're going to benefit from this as well. And I think specifically from the studies that we do have, those patients that have like a single LAD CTO are among that group of patients that you may want to consider being more aggressive for. For patients with multivessel coronary disease, so complete revascularization, I think to be determined where that lies. I do think it's worth mentioning that although we don't do much CTO PCI just for a native vessel initially, we do refer a lot of them for surgery, and then they're coming back with the issues thereafter. And so if we do think about complete revascularization when we send someone for a CABG, I think it at least challenges us to think about why we're not thinking about that for patients that have CTOs as well. And then less certain indications. So for patients that have extensive ischemia, not really sure how to fit that in. And then this idea of double jeopardy is based on that patient population that does not do well after they have a STEMI if they have a CTO in another vessel. So we know that those patients don't do well in the early and in the long term. And so there is, some people have proposed doing, CTO PCI before they have their STEMI. Not sure how you guess who's going to have a STEMI, but that is one thing that is sometimes talked about within the CTO community. So pulling all of this together, CTO PCI, obviously a very complex procedure. It's available for challenging patients that are dealing with, symptoms of angina. And that's truly where the best indication is for moving forward with CTO PCI is to help with anginal symptoms and to improve overall quality of life, to get our patients to have higher exercise tolerance, to make them more active and more mobile than they already are, or sometimes are not even able to be. We know that with going through all of the randomized control trials, that there has not been shown to be a difference in mortality with doing CTO PCI versus medical therapy. Observational trials, there's a lot of data that's out there. Most of them are very small trials. There have been some that have suggested that certain subsets of patients may do better. I think the ventricular arrhythmia trials are pretty interesting. I mean, the numbers were pretty impressive with the differences between how many ICD therapies they were getting. And I think that might be important when thinking about those patients who do have like an isolated CTO and have had other revascularization, but continue to deal with having ICD shocks. Also in the way of this potential long-term survival, again, not really comparing apples to apples, but there is some data to suggest that those patients that have had good revascularization may do better as time goes on. I think the development of investment procedures with STAR and SPAM has been really a positive thing for the CTO community. It's improved the safety, and that's really the reason that it was created, was to take patients that were having procedures that were hours and hours long, where they were unable to finish the procedure or where they ended up with a full metal jacket of stent, and saying, is there a way that we can cut back on this and bring the patient back, allow them to heal and do better? And so I think that that is a great practice personally. And I think it's really important that when you're discussing CTO PCI, that it should be something where they are under the understanding that they are going to probably have more than one procedure. Imaging studies may be helpful in determining who can benefit from CTO PCI, but every modality is met with some limitations. And I certainly don't think that there's any data that tells us that every CTO patient should have a certain type of imaging study. We know that robust collateralization is not a reason to stop with an idea of revascularization for a patient. We know that that's not really telling us very much. We know that the aging population with a prior CABG is an incredibly complex and really difficult population. Their CTOs are much more complex than those that have not had a prior CABG. And as that population continues to live longer, I think it's important for us to think about our decision-making when we are referring patients for CABG. With that, along the same lines there, hybrid revascularization, potentially that may be something that we all take a step forward towards in the future, where we're giving patients that long-term benefit with their lima, but we're not subjecting them to all of the complications that come with saphenous vein grafts and the problems that revascularization of those lesions later on comes with. And then just as time has gone on with advances in technology, advances in intravascular imaging, with there being a big CTO community and teaching people how to safely do CTOs, there's been an overall improvement in the success rate and a decrease in complications rate as time has gone on. And certainly I think the goal and the goal as far as that goes is to continue along that same track. So I have a number of references here, and I'm happy to answer any questions. This is my cell phone that's listed there, so please feel free to reach out to me about any patients if you are considering moving forward with a PCI for them, or just want to talk about the option of CTO PCI for them. I am more than happy to talk to you at most times of the day, but that's my personal cell phone there. So please feel free to reach out.
Thanks so much, Dr. Frampton. We'll open it up for questions. There we go.
Yeah, I can start. Thanks, Jennifer. That was wonderful. And I think it's great to kind of get us all up to speed on this as this field is kind of shifting and changing, and to see you take an increasing role in pushing us forward in this area is great. My question relates to, are there basic expectations around who should we pursue a CTO, and what in your clinical practice are you doing to ensure that we're not doing that as a first line, but as a subsequent response to the failure of medical therapy and other things? So could you take us through your kind of clinical practice? If someone refers you to a patient to you for clinic, what are the kind of approaches in terms of quantifying the quality of life, the anginal status, and whether medical therapies have been used sufficiently.
Yeah. Yeah, I mean, I think that's the most important thing, right? You have to feel as though medical therapy has been attempted and that they are still not doing well after they've had medical therapy. And so sometimes it's very patient specific, of course. I will say that I tend to favor a more aggressive approach for a younger patient because they can be a lot harder to tolerate. It's often harder for them to tolerate anti-anginal therapy and they don't like to be on anti-anginal therapy. And so for those patients, if they have a proximal LAD CTO and they have been on a anti-anginal and are still feeling as though they can't do what they want to do, they're young, they want to exercise, they want to be healthy, I think that that's a very different patient than, you know, an 85-year-old who's post-CABG and has this terrible CTO that's 70 millimeters long. Then that patient, I'm much more likely to continue to push as many medications as possible. But I think kind of the long and short of it is that they have to have at least tried medical therapy. The data just doesn't support doing it without having that trialed at first. And then I think from there, it's very much up to who the patient is as a person. And so, you know, myself being incredibly passionate about exercise, for somebody who wants to get back to exercise, I am always going to consider that a very important focus where I really want them to be able to do that. And so if that's the group of patients that I'm looking at, then I like I said, I will be more aggressive in trying to help them to get rid of their symptoms so that they can do that, so that they can improve their life and their longevity by being active. So I think it's very patient specific, but I of course do think that you have to put medical therapy first and foremost. And I think it's important for patients that are going to have a riskier procedure, like that post-CABG patient that I mentioned, that you really do make sure that you have really tried medical therapy, multiple anti-anginals, and still kind of proven that this is an issue for them. Get them on the treadmill, see what happens, see what their exercise tolerance is truly like. I think that's helpful as well.
So great review of the topic and excited to see that imaging is used to sort of triage those patients. I wonder about the role of imaging in the post-treatment follow-up, particularly maybe in the ones where, you know, how does it relate to the arrhythmic risk or remodeling post-intervention?
Yeah, I don't know that I know the answer to your question. I mean, I think the majority of time what we end up doing is we'll use the perfusion imaging or the MRI for the initial understanding of viability. And then from there, they just get echoes. So they don't really get a second cardiac MRI or another perfusion imaging study. And so I'm not sure that we really know that answer, honestly. I mean, that's what these smaller observational trials have tried to look at, but they're of course limited by their size and all of those sorts of things.
If you compare sort of our knowledge of CTOs and whether it works or not, I think there are some other areas in interventional cardiology that are a little bit similar but for different reasons. So we can take Impellas, right? And it looks like Impellas would work really well if we didn't have a lot of complications with them, right? If you don't have a complication, it seems to work, but we know our complication rate's really high with them. Or you can take something like renal denervation where it doesn't have a lot of complications, but it's really hard to figure out who's the right patient population to work in. CTOs seem to have sort of both of those things. They have a higher complication rate and we're not sure. And I'm wondering, to what extent do you think it's more similar to Impellas? We've just got to figure out how to do this a little bit safer and get our equipment a little bit better. Or it's like renal denervation. It's like a sort of this very smaller set of patients that we may benefit from.
I think it's personally, I think it's more the Impella type where we just have to understand how to do these procedures safely. And that has evolved so much over just the last 20 years or so. And of course, I anticipate that that's going to continue to evolve. I know that within discussions among other CTO operators, that's of course very much a focus that our procedures have a higher complication rate. And so minimizing that as much as possible by developing these techniques is the goal. And so I would put it more in the Impella realm as far as that goes.
Jen, great talk. Thanks so much for sharing with us. I guess I have one request and one question. The request is if you can give us a little bit of information about kind of like your journey into this space, because when you first came, you didn't have that training, and you've been very thoughtful and diligent about how to acquire it. So just sort of like your reflections as a junior faculty member who sort of refashioned themselves after training, which isn't something that we typically think is possible. I think for the fellows here, might be interesting to kind of hear what your journey has been. The second thing is just to talk a little bit about the complications piece. John, I mean, it's sort of about comparing apples to oranges when we talk about regular PCI versus CTO. But if you do look at other forms of higher risk PCI that we look at, there is pretty good observational data that the complication rates are actually quite similar to road ablation procedures or left main. And so it's a little unfair to sort of single out CTOs as being that much higher risk, because really in reality, in the real world practice, they aren't currently.
Yeah, I think that's a great point. So yes, I mean, I had not done CTOs before I came here. I had always been very interested in high-risk PCI. I did a ton of high-risk PCI where I trained, and I loved that. I just didn't have the exposure to CTOs. We weren't doing them where I trained, and then came here and had watched Yusuf do cases, and had just essentially asked if I could learn that as well. So I went out to Seattle a couple of times. I did some hands-on training with them, and then I double scrubbed with Yusuf for like 10 months before he left, and did all of the cases with him coaching me and teaching me the entire time. And so I feel super fortunate to have had that experience. He was a wonderful teacher. But I think it was just kind of my interest in high risk and complex PCI has always been there. And this space, I just hadn't had the exposure to. And then once I did, I of course thought it was like fascinating and wanted to know everything about it and wanted to do these cases. So, so that's kind of how the opportunity came about. And I just think, you know, coronaries, of course, I'm like very passionate about them. I think they're the most interesting thing ever. But this just seemed to be a space that I didn't have knowledge in, and I wanted it. So.
Thanks, Jennifer. That was a really great review, up to date. And John and Jeff had mentioned complications. So I was going to say that I was amazed that you said STAR made the procedure safer. I'm old enough that when I hear subintimal, the next word I think of is perforation. And that's a word that you didn't mention once in the entire call. Perforation. But let me ask you another question. I'll just, leave that behind. Do we have any idea why robust collaterals aren't good enough? Why they prevent, do they not anastomose physiologically with capillary beds, so myocardial perfusion is impaired? Because I know piddly collaterals you wouldn't expect to do the job, but you kept using the term robust.
Right. I don't think I know the true physiologic answer to that. I don't know if anybody else does, but I think there's just enough data to show that it just isn't enough, that they're just not getting the blood flow that they would have if they had native vessel PNC.
Okay, thank you.
Maybe oh, great. I my knowledge you have one. So to Jeff's John's point, I think literature on complete revascularization versus not complete revascularization is quite strong in surgery, and actually one of the challenges of the non-surgical revascularization strategies, which is that we couldn't accomplish that. So I think this increasingly becomes more safe, then I think the question needs to be asked whether complete revascularization, whether it matters how you develop that.
Yep.
And that may be a place where CTO kind of starts building stuff foothold. If the plug is really to just remind everyone, we're very excited that Mark Ruel is joining us officially March 1st, and he'll be chief of cardiac surgery. And one of the programs that he's put in place, and I believe last year did over 200 cases of hybrid revascularization without external entry. And so I think this is an area where many of our physicians listening by Zoom will start perhaps referring patients for evaluation to you and to
Yeah.
the team to prepare for that, because there might be patients who are sitting on angioedema symptoms who have not had, really good options for non-surgical evacuation through traditional approaches, where hybrid strategies might be something we will, it certainly have shown, he has shown the ability to create that program in the institution. That's relatively rare. As someone who wrote papers about hybrid resistance when I was a fellow, it had never kind of gone to a phase of kind of like large adoption, and it's great to see it perhaps moving in that direction.
Yeah, that's really exciting. That's great.
Much to answer your question.
Erica Spatz. Erica Spatz
Do you-
asked, you referred to several different outcomes, symptoms, improved LV function, a risk of heart failure, MACE. What holds the most promise and what should we be aiming for?
So I don't know the answer to that, honestly. I mean, I think the data that I thought was personally the most interesting was the ventricular arrhythmia data, because I just thought that the numbers were so striking between people getting shocked and people not getting shocked. I don't know that we're ever going to get another randomized control trial in this space. I mean, I think that there has been attempts at that, and it's been incredibly challenging. The enrollment is very slow. There's tons of crossover. All of the problems that we saw with decision are going to just be problematic moving forward. So I don't know that we'll ever have like a true answer to all of those questions. We have some of these observational trials, and that's helpful. But I think that I don't know, what will be really the space where we're going to focus the most. I think in the few cases that have been specific to those areas, I've done CTOs for patients that had reduced EF. I've seen it recover. I've seen it not recover. I have done CTO PCI for the arrhythmia piece, and that has settled things down. And I know Yusuf has had similar experiences from talking with him. So for me, I think that that's like a very interesting piece of things, right? We know that ventricular tachycardia is often from SCAR, which is often associated with CTOs. And so I think that that's a space where we probably underutilize CTO PCI. But as far as, what will we find in the future? I don't know that we'll find really anything as far as like another RCT goes, because I think there's just been so many problems with trying to do that realistically.
Very good. Thanks so much.
Thanks.
I always thought.